not sure.
It's
Is that
the upper camera. I had to change it.
oh, okay? Okay, can you get this up?
Yeah.
Okay, we should be live right now. So, hello everyone. Welcome to this episode of the TOT Doctors Roundtable, hosted by the lifting dermatologist. If you are new to this channel, please do subscribe and hit that notification bell so you don't miss anything. Today we are joined by Dr. Jim Meehan for the first time on our podcast. Welcome, Jim. How are you?
Hey, thanks for having me. Good to be here.
Thanks, my pleasure. And we're also joined by Russ Scala, expert in performance and TRT in medicine for 40 years and writer of The American Biohacker, a book you can buy on Amazon. Hi, how are you, Russ?
Good to see you guys. Glad to be here.
Yeah, glad to have you on the channel. So these two hormone experts, together with Dr. Keith Nichols, Dr. Scott Howell, Dr. Rob Kominiarek, and Dr. Meryl Maschke, are all part of our hormone optimization therapy team now at the Facebook group called TRT and Hormone Optimization Therapy, HOT. So if you haven't already, please do join that group on Facebook so you can post all your hormone-related questions and concerns right there. The link you will find under this video. So that's so far for the introduction. So last week we already had Keith Nichols and Scott Howell on this podcast, and we had their short introduction to their TOT world. So let's start with Jim now. How did Dr. Jim Meehan get into the optimization of hormones, being an ophthalmologist and all? Tell us, Jim.
Right. Well, I started my career in ophthalmology. I spent the first several years of my career doing over 10,000 surgical procedures of the eye, mainly LASIK eye surgery, a lot of cataract surgery, and then a whole plethora of other surgeries. But eventually I was really frustrated by a healthcare system that paid doctors a lot of money to treat the end stages of disease, but did so little to prevent the diseases. So as an ophthalmologist, I would be paid thousands of dollars to treat a diabetic retina with a laser. But I was paid nothing, to talk to the patient about diet, exercise, nutrition, and all of the things that they can do to prevent disease. So I started a company that called Catalyst MD that I still run today that is focused on using technology better, trying to empower patients with preventive health information. About this same time, I was really struggling with my own health. I've always been an athlete, high level martial artist, MMA fighter, and Muay Thai. But I found myself, I'm 6 foot tall, and I found myself about 300 pounds, fat, sick, depressed, nothing, it felt like all of my life was behind me and just no hope for the future. And I wasn't a good father. I wasn't a good husband. I wasn't the man that I was supposed to be, that I had once been. And so I went to the best doctors in our market, and I got all of my symptoms got treated. I got put on antidepressants and weight loss medications and statins, and nothing made me feel better. It all, in fact, made me worse. I got side effects from all of those medications. I was working hard, back in the martial arts studio, lifting, running, and all I was doing was breaking my body down. I finally did some of my own testing with the help of a doctor friend of mine, and I diagnosed my testosterone deficiency. I had a total testosterone of 138. Back then, I didn't even know to test, free T, but I was, that was my problem. And so I went back to my doctors and I said, I think this might be the problem. Can we try this? We've tried everything else, and all of that, everything else hasn't worked. And they're like, oh no, you don't need to worry about it. You're almost 40. No reason. That's not the problem. But I persisted, started, I went down all the wrong avenues, pellets, an injection every 2 weeks, things that the mistakes that guys are still making today. And over that process, I decided I was going to become a scientist of my own health. I was going to, figure out how to treat the problem. And it just began a quest for me. I trained with all of the leading, the thought leaders, did all of the seminars and courses and everything I could possibly do. I actually even trained with, I did the Synergenics training, all of those kind of things. And I eventually, I got my hormones optimized or improved dramatically. And it changed everything in my life. I mean, I lost the weight without even hardly trying. My brain came alive again. My mood improved. And I became, I just became a better husband, a better father, a better doctor, and just a better human being. And it was such a transformational process for me. I mean, when you see your life falling apart, your relationships falling apart, and you just, you're a part of the problem, but you can't find your way out of it. And then you do, like somebody turns on the lights, that transformed everything for me. And I said, I just want to be a doctor that does that for my patients. Instead of just treating the end stages of disease, I wanted to, give them that transformational medical care that I had received, that had, given me my hope, my future, everything back to me. So I pivoted my career, and I've been in it ever since. It's the most satisfying thing that I've ever done. I mean, when we optimize and improve and we treat the underlying causes of so many of these diseases, chronic diseases like diabetes, that have as their foundation a hormone deficiency, we're really practicing medicine. We're real healers. And so I think it's just the most satisfying thing that I've ever done. I certainly made more money doing, high-end procedures and surgical procedures, but I was empty inside in that process. And now I'm filled. I love what I do. I love restoring relationships. I love seeing men, go from that place where you're so inwardly turned to that place where you're just giving to your community and everyone around you. So I feel like what we're doing is transforming a culture. We have the potential, if we get more men and women out of their hormonal disequilibrium, imbalance, and disease, that we can literally change, the face of this country, the face of the world. So that's what I'm committed to at this point.
Wonderful story. Thanks. And Russ, how did you become an expert in performance and TRT? What is your background history?
Yeah, I think I had a similar history as Doc there. Amazing story, Doc. That was all passion, brother. Let's start right now. I'm considered right now. I have a team in Orlando, Florida. We're an 11th hour interventionist. We work with brain injury and cancer, and actually apply TRT to the disease specific market. I have a few physicians here in town that take care of our clients in the city. And that's sort of what we're doing right now. I started the Russ Scala YouTube channel, like you're doing, to educate the masses out there, because my history is a little different. I started as a paramedic attached to the SWAT team in the early 80s. I got really sick and really depressed and responding to emergency calls and ramping up my cortisol levels and low testosterone. So what I thought I'd do, like Doc, I became a triathlete thinking that was healthy. And I raced for 20 years. And guess what? It made everything worse. I was racing all over the country doing half Ironman races. I couldn't get an erection, but I had a great tan, So, and of course, I didn't have any doctors to go to at the time. And we become self, we try to run our own lab work and try to figure it out ourselves. Or luckily, I had a good idea of anatomy and physiology. I understood what drugs do to the body. When I became, one of the things as a triathlete, you have to understand the Krebs cycle. If you want to go long distance, it's all about your brain. It's not all about muscle. Well, fast forward 2004, I became the research director for Signature Pharmacy, and that allowed me to be on the tip of the spear. I set up over 25 anti-aging centers from Boca Raton to Beverly Hills. I was working on long-acting growth hormone. I brought in a nutritional testing protocol that tied into their hormones that looked at the Krebs cycle and the microbiome back in 2004. So we were way out on the tip of the spear. I've got to look at that thousands and thousands of sets of blood work. And like Doc said, I was like, wow, I knew in 2004 that we were going to use testosterone and growth hormone and IGF-1 to rehab brain injury patients. I mean, I've been working on brain injury patients since I was a kid as a paramedic. When I used to work in CCU and wondered why some brain injury patients would leave the hospital sooner. And what we know now is if you elevate growth hormone, testosterone, thyroid, you elevate that HPA axis during brain rehab, you'll stimulate neurogenesis and synaptogenesis. And what's even interesting, if you apply testosterone at the cellular level, it's going to produce less free radicals during the healing process. So this is all blue water stuff that we're talking about. And I just want to be part of a team to educate people. I mean, I have a lot of information to share. I'm still as passionate about this as I was when I was a kid working in the emergency room. I think I'm totally curious. And like Doc said, it's my passion. I like getting people answers at the end of the day. Like I love it when I get a client that said they've been to 4 physicians in the Mayo Clinic. That gets me out of bed in the morning. So was that a good overview, or was I too ADD with that?
That was great. I love it.
Okay.
Okay, so I have some questions for you guys, and for all the viewers, feel free to add your questions into the chat box. Stu Walker just wrote, when Jim just spoke there, it's the most profound thing I've ever heard any person saying regarding optimization, Jim. So that's
Thank
for
you.
Okay.
It comes from the heart. Yep, it does.
Then for the questions that already appeared in our Facebook group, Sam Cook from the UK asked, how do you guys manage adrenal issues, specifically low cortisol? Do you use low dose hydrocortisone or DHEA and pregnenolone instead? Maybe you start, Russ.
Yeah, only, again, one of the things that I want to paint a picture for is we got to understand this. Everybody is biochemically unique. We cannot treat hormones in isolation, can't treat the thyroid, can't treat adrenal glands in isolation. We have to look at the HPA axis. We have to look at a 4-sample cortisol saliva test, and then look at the saliva test and then see where the person is either high or low, and then tie the symptoms in other words, we can't just rely on lab work. We have to treat symptoms as we all know. So I would say get testing, understand that your stress level, high cortisol or low cortisol can determine the dosage on your testosterone levels. So I would want to get, we use between 5-10 milligrams of hydrocortisone at different parts of the day. I still work with a lot of endurance athletes. They're always pushing out the cortisol levels. So an endurance athlete, a male that's training for a marathon, may have higher cortisol levels, and his testosterone levels at 900 are not enough because he's training for a marathon, if that makes sense.
Yeah, sure.
Okay.
Jim, you go.
So so the issue of adrenal fatigue, and everybody has different ideas. I always start from the basis that so much disease is driven by inflammation. And that's a major stressor in everybody's, physiology. Everybody's body is on fire nowadays. We know, Russ mentioned his experience with the treating traumatic brain injuries. And I also treat that population of individuals and soldiers and veterans in particular. And one of the things that we have to do is we have to shut off their fires of inflammation that are burning in their brains. It's a primary cause of a lot of the dysfunction that if your brain's on fire, your HPT axis is going to be out of equilibrium. Exactly. So you have to start from a basis of decreasing inflammation throughout the body and all of the sources that it's coming from. I created a framework called Mindset that is it's what I use to kind of address the 7 key elements of health, wellness, and vitality. So if you can imagine the acronym Mindset, it's the M is for the mind-body connection. And I also focus on that in the microbiome and mitochondria. But the I is inflammation control, N is nutrition, D is detoxification, S sleep, E exercise, and T is total hormone balance. And so I always start in those areas. I teach little segments on each one. And by the way, Russ, we're turning that into a technology platform and a smartphone application that gives people the opportunity to, they get a score in each category so they can see where they're. So we're using biometrics and wearable fitness devices like the Oura Ring, one of my favorite new biometric measurement devices. But I'm trying to, I don't want to get too far away from the topic of adrenal fatigue, but it all relates and has this foundation in decreasing inflammation in the body. So you got to learn how to deal with stress. I think the psychological stress is one thing. My experience has been that there's environmental stressors, there's inflammation going on in our body, and that manifests in our psychology, our psychiatry, our brains as, this perception of everything from depression to bipolar disorder to a number of thought to be organic brain diseases that are in fact, I think, driven by brain inflammation. If your brain's inflamed and you're putting out of equilibrium the neuropeptides and proteins like orexin, which is the alertness kind of molecule in the body. If your corticosteroid releasing hormone, if your hypothalamus is not speaking to the adrenals properly, I think this is when we most often kind of develop the symptoms that we call adrenal fatigue. I think the adrenal glands are fairly capable of, handling a great deal of stress. I think we can also, wear them out, especially if we're, eating a diet that isn't providing the raw nutrients that are so necessary for all of these, biochemical reactions. But if we don't recognize that we got to start from any disease process by cleaning up the diet, by improving the way we sleep, making sure that we're protecting ourselves from this environment of, we're swimming in seas of toxins. And the more toxic, toxin testing that I do, I use labs like Great Plains Laboratory to measure toxic load in my patients. And the sickest patients are carrying the highest toxic load, like levels of glyphosate that you just would not even imagine. I have, the levels of these organophosphate pesticides that people are carrying in their bodies. And this stuff is just creating such tremendous inflammation that everything's in disequilibrium. So you got to clean that stuff up first. In the interim, you have to supplement everything while you're kind of, you can't just, the mistake I think a lot of docs make is they want to clean up all of the diet and do all of those good things. Perhaps most of them don't, but simultaneously you got to kind of replace what's obviously deficient. So you got to measure their pregnenolone levels. You got to measure their DHEA levels, their hormone levels. And when you have an objective evidence for a deficiency, you got to measure their cortisol, in a diurnal 24-hour test with salivary or urine. You got to test these kind of things. And when you identify a deficiency, replace it. Hydrocortisone is a powerful medication. You want to be careful about using it for long periods of time. Most of the prescriptions that I write for hydrocortisone are tapering people off of it while we're doing these other things. But it has its place. I mean, when you're markedly deficient, that brain's still on fire, maybe the communication axis is disrupted. You got to bring these other things into balance. But at the end of the day, gentlemen, you've got to understand that you can't just take a pill or a hormone and do an injection or rub on a cream while you're still drinking far too much alcohol, you're taking opioids, you're on ADD, amphetamines, or all of these other things that are at their core primary drivers of the problem.
Okay, nice. And then he extended his question to how would you support adrenal issues that may be caused by low thyroid while thyroid is being optimized? Maybe you continue, Jim, for the moment.
Sure. Well, yeah. So there's thyroid and adrenal issues are intimately connected. There's often an inverse relationship. So if you have one of the most common autoimmune diseases in the world is Hashimoto's thyroiditis. What I believe is primarily an autoimmune disease driven by disruption of the gut microbiome, leaking of proteins too large to enter the tissues and the vascular system. Our immune system sees these large undigested proteins that sifted through the wall of the intestinal barrier, get into the body, and they look a lot. Our immune system targets them, and they look a lot or match proteins that are on the thyroid. And as a result, we've got a thyroid that's under attack and manifesting episodes of hyperthyroidism or low thyroid activity, and that's going to affect the adrenals in a very significant way. So again, you got to kind of start with what is the first link in the chain? What is the primary cause of the condition? More and more evidence is pointing directly to the health of that gut microbiome. I don't know what you guys think, but the more science that I see, read, hear, watch, the more evidence is strongly pointing to this very important microbiome, and it's important to keeping the bad things out. And we've got molecules like glyphosate that are big disruptors of the microbiome, and that glyphosate is ubiquitous in our environment. 75% of rainfall in this country, it's in the cereals and the breads that you see little kids walking around with those Cheerios in a little plastic bag, and the amount of glyphosate that has been measured in those Cheerios that we're feeding our children is unbelievable. It's extremely unhealthy. It's extremely disruptive of that gut microbiome. So yeah, I mean, we've got to deal with the core issues. And as we deal with those, it gets a lot easier and it's a lot shorter to treat the deficiencies and replace the deficiencies in that thyroid that's struggling. I believe that, our bodies have an almost unlimited potential to heal themselves if we just give them the right resources, nutrients, sleep, exercise, hydration, and they'll fix themselves. So our job should be primarily to deal with the underlying causes for a short period of time, replace the hormonal deficiencies, and get them on a path of self-maintenance that prevents these toxins from constantly coming in and causing the problems that they cause.
Yeah, sure. That's your experience as well, probably, Russ.
Yeah, I mean, I went to the Great Smokies Diagnostic Lab in 1996 to start a stool testing up there with that lab. Everything Jim is saying is spot on. When I'm face to face with somebody with my team, this is what I got to think about. What are they going to respond to? Okay, half of them are ready to jump off a cliff. What's going to get results right away? Because if I get results, then I get compliance. There's a lot of study in neuroendocrinology right now that even childhood trauma can cause imbalances in the brain chemistry that can affect us as adults. So when I do a backstory, when I meet people at the 11th hour, they want answers and they want to feel good. So what is that going to be? Do I look at like Jim said, the adrenal glands and the thyroid work hand in hand. You cannot treat these things in isolation. If we elevate T3, will it bump up the dopamine levels with a little testosterone and get them off an SSRI that may be damaging the prefrontal cortex over time? So again, I just got to have a wide toolbox, and each patient is biochemically unique, and I got to see, I'm dropped into the second act of a third act play a lot of times. And a lot of people, they got short attention span. They want results right away. And it's always trying to navigate that sort of puts me in the weeds sometimes,
Yeah.
Yeah.
The last question.
I wanted to add to that, Stephen, if I could. I mean, what Russ said about being in the second act of a 3-act play, we're coming into this late. Many times, one of the biggest problems that we're dealing with are these powerful prescription medications that, everything from antidepressants to opioids to benzos. We have a culture that is based on big industry creating products that are engineered to create addiction. They're engineered to stimulate the release of dopamine and we become very dependent on those products, whether it's, 19 teaspoons of sugar in a 12-ounce Mountain Dew, or it's a, antidepressant that the clinical evidence says doesn't work, beyond 6 to 9 weeks. We overuse antidepressants and we end up just creating, receptor-based dependency. You're locked in, somebody that's 20 years on Prozac or any of the other, number of antidepressants, those doctors that lock them into that dependency have created more problems for that patient. And it's really difficult for what we do to get them off of those drugs. This topic also goes, this opioids. One of the biggest things that I found the most benefit in our treating our soldiers with TBI and PTSD is understanding that opioids create neuroinflammation. We now know that opioids stimulate cytokine release, and they bind to opioid receptors on microglia in the brain, and they stimulate inflammation in the brain. One of the reasons that it's so hard to come off of opioids is because they have progressively set the brain on fire. And that burning, one of the things that you're trying to do to escape the pain of that inflammation burning in your brain is you're seeking more and more dopamine stimulating products. And you get locked into this opioid dependency thing, pulling patients off of opioids, off of all these, homeostatic, disrupting, imbalancing drugs like antidepressants is so important to healing, so many of the things that we always talk about. So many of the guys on the message boards, it's like, I just want to ask, it's like, please show me your med list, because when you're describing the problems that you're describing on the message boards, I know that someplace in that medication list is an antidepressant, is probably, some sleep medicine. There's, you know what I'm saying? I know you guys see it too. It's just like, we got to be honest about the ineffectiveness of so many of these drugs that are being used to treat the periphery of a problem.
Yeah, exactly. I see patients coming in for dermatological problems on a daily basis, and when they're 60, 70 years old, I'm always very glad when I ask what medication are you using, that they say, well, none. I think that's amazing, because most of them are,
and it's rare.
Statins, blood pressure medication. It's unbelievable. Most of the 60 plus people, they have a whole list of 10 or more drugs actually that could be prevented by good nutrition, working out or whatever. And yes,
I think what Jim said about the inflammation, if we think about the CBD and THC being knocking out the inflammatory markers, we've got natural endocannabinoid receptor sites in our brain and different organs in our body. And I think that's going to be a treatment protocol moving forward just from the inflammation side.
I do too.
Yeah. And the next question was, do you guys have any preference in split dosing versus single time of day dosing for thyroid meds? I thought that was a good question as well, because I take thyroid meds over 20 years now, always in the morning before breakfast. But is there any advantage in twice a day dosing maybe? I have no idea, Jim.
I lean towards twice a day dosing. For example, if somebody comes in to me on say 60 milligrams of Armour or NP thyroid, or usually they come into me from the traditional healthcare system and they're on Synthroid. And so I immediately transition them away from that. And Synthroid, of course, they're never put on coenzyme Q10. So, it's just mismanagement, but I'll usually put them on. My preference is desiccated glandulars, and I'll usually take whatever dose that they were on once a day, and we'll start off by dividing it. And then I have them, I turn them into a scientist of their own health. So I have them check their body temperature in the morning. I have them check their pulse. There's things that you can measure at home that give you some kind of indication as to whether, you're therapeutic or subtherapeutic. and then share that information with me. And then we use that information to kind of, improve, decrease, increase, but to dial in their treatment.
Okay, you do that as well, Russ? Twice a day?
You know, since I deal with the outliers and the athletes and the people that are severely stressed out, if we're gonna recommend splitting a dose of thyroid, everything Jim said, you know, is spot on. I agree with 100%. But a lot of times, since the thyroid medication can stress the adrenal glands, we look at the adrenal cortisol saliva test and we see where the peaks and valleys are, and then we try to dial in the thyroid with the adrenal testing. And then obviously, you know, we want to treat the whole HPA G axis along with the microbiome and the mitochondria. So I try to pull all the puzzle pieces together and then spend a lot of time, my team and my docs spend a lot of time, like Jim does, with, you know, with the patient. We got to get a really good backstory. You know, a bad phone call after 3 o'clock can bump up cortisol, and these people can cycle bad thoughts in their head for 3 days. Those are the people that I deal with.
Right.
Okay. Right, that's clear. Another man asked, Ricky Ryan asked, something to discuss at the next roundtable, please. Testosterone undecanoate in a pill form. Can it be a possible option? And what about the issues with the liver? I know here in Belgium it's on the market already a long time. I believe it's coming to the United States now as well. I don't know if you have any experience with it, or what your opinion is on it, Jim.
My opinion is pretty low about, you know, oral delivery of testosterone. You know, that to get any hormone past first pass metabolism, well, even, you know, digested, and then first pass metabolism through the liver requires that you really, you know, you have to send more down the tube to get it into the cardiovascular system than you really should. And you've got all of the problems with absorption and guts that are not as healthy as they could be. We have so many people that are, you know, on proton pump inhibitors, decreasing their stomach acidity. There's so many places that you can go wrong in absorbing a oral form. So I'm just, I don't see a place for, you know, undecanate in my clinic, in my practice. I don't think it makes sense. It makes dollars for the company that's selling it. And it sounds like, you know, a reasonable tool to somebody that is, you know, a consumer, but as a physician that has, you know, is an expert in this area, I'm staying as far away from that as possible.
Yeah,
I agree. We measured 2 of the detoxification pathways, one with acetaminophen and one with aspirin, and people that have taken oral steroids on their own have damaged both these detoxification pathways. And if we study the history of how this stuff evolved in Germany when it was taking away chunks of liver and producing high levels of 17 alpha alkaloids, we know to stay away from the orals. It's just not a good idea, guys.
Yeah.
Okay, that's clear. We'll stay away from those. But they're not prescribed here in Belgium anyway. So yeah, a difficult question, a long question actually, from Michael Angelo Kilty. He wondered what are the standard reference ranges, and where should we be at with those ranges? And he's talking about TSH, free T4, free T3, and TPO antibodies. So I already wondered myself as well, Jim and Russ, when is a thyroid optimized really? Do you look at numbers, or do you only treat symptoms like for the testosterone?
Again, I think Jim can articulate this as well. Everybody's biochemically unique. We can't chase numbers. We have to look at symptoms. What if you're on a thyroid medication, you're going through a divorce? You're gonna have to change and look at the thyroid testing, because things are gonna go south on you. You know what I mean? If that makes sense. The amount of stress that you have in your life, combined with the environmental toxins, whether you have elevated estrogen levels or whatever, estrogen causes a lot of problems with the thyroid. You just want to understand you really can't chase numbers, and what's optimized for you may not be optimized for the next guy. So we don't want to use any sweeping generalizations here. And this is why all the doctors that I talk to, they go, Russ, I don't have any time for this. You know, so I don't fault anybody, and I never judge anybody, but this takes some time.
Yeah, I'm going to take this question in two parts. So the first part seemed to be about reference ranges. And so, you know, I'm watching these reference ranges go from, you know, like 500 to 1300 of where where they were about 15 years ago when I started, to, you know, like I saw one of the labs that I'm using here in Tulsa, Oklahoma was like 216 to 7 something. You know, it's like they keep shifting down. The population of the United States of America and of the world is getting sicker, fatter, sicker, more inflamed. And as a result, we got reference ranges that are reflecting that. So the optimal reference range, in my opinion, and there's a lot of different reference ranges from different labs, right? You have to understand that. So the general rule is my optimal ranges are a little bit higher than those standard reference ranges. I'm basing my optimal treatment targets based on the healthiest members of the population, elite athletes. We have tremendous data from Olympic athletes, for example. There's a rich amount of data on testing of Olympic athletes. During my residency training in ophthalmology at Washington University in St. Louis, I participated in some studies of the St. Louis Cardinals and the hockey team, St. Louis Blues. And what we found in those, you know, healthy 20-year-old young men, I was a part of the eye study. By the way, I figured out why all baseball players, you know, why I wasn't as good at baseball as I was at martial arts, because a lot of these guys had 20/10 vision, you know, the ability to see the no high order aberrations. They just were gifted with exceptional vision. But one of the other things that they were gifted with were hormone levels that were, you know, standardly in the 1200 to even 1600 range. You know, they had all of their, you know, their estradiol was in the 50 to 70, you know, range. And so my targets are more geared at Olympic athlete levels, you know, the healthiest people, and the youngest portion of the population. And that for me is often the target. It's all, you know, until we do something like I want to call it hormonal fingerprinting, where we measure your hormone levels when you are at your, you know, your optimum, your most vital, youthful levels. We don't really know what the best targets are for any given individual. You know, Russ's might be 1400 and mine might be 1000, you know? So in general, we don't have that ability to know what an individual's optimal range is, but we do know that they're safe and effective in certain ranges. And I try to treat to a target that is often somewhat above the standard reference range, if not always. And then the second part of this question, with regards to the thyroid testing, you know, I think first and foremost, we treat patients, not numbers. I do use thyroid testing. And if I'm going to do a thyroid test, I'm doing a comprehensive panel. I'm looking not just at TSH, that tells me so little, but I'm going to look at, you know, free T3, free T4, reverse T3. That's an important value to look at. I'm going to look at their antibodies, TPO, thyroid peroxidase, thyroid antibodies. I want to know if there is a clinical history, or if there is a demographic, like a 35-year-old female who has a high prevalence of autoimmune thyroiditis. I'm gonna make sure that I know whether she's, you know, he or she has some autoimmune attack going on with the thyroid. Beyond that, it's really, I'm treating to the subjective systems and symptoms. But one of the things I have to be cautious of as a physician in the United States is, you know, I have to be practicing evidence-based medicine and make sure that I am, you know, at least measuring the effects of my intervention.
Yeah, I understand. You know, here in Belgium, in the laboratories, you can only measure TSH, and then you have to choose between free T3 or free T4, and that's about it. You can't have them both. If I dash them both, the laboratory will measure only one of both, in most cases free T4 even, and then they will say, well, TSH free T4 is okay, so we haven't measured free T3, and that's about it. So,
yeah, that's crazy. So they actually control how you practice medicine.
Yeah, we can't do anything about it. I've tried several times on the paper. I need them both to optimize. Well, whatever they said, the others are fine. So go ahead. Yeah. So the other question about thyroid hormone was, since it's one of the two feel-good hormones next to testosterone, how prevalent is the need to correct thyroid levels if one is already on TRT? So
yeah, I'll take that one first, Russ. Yeah, so I usually like to start with hormone, start with the sex hormones first. I believe that I want to be a scientist. So I want to try to deal with as few variables at a time as I can. So I don't want to intervene on both at the same time. I typically will start with the sex hormones. Like Russ said earlier, you got to get some results for your patient so that they're feeling better, and it starts a cycle of success that will continue on. So you want to start with those things that deliver the biggest response and the results. The sex hormones will always do that. So if they have a deficiency there, I start with sex hormone optimization, and then you'll see an improvement in their thyroid function when you start renewing and restoring that intimate relationship between those two very important systems. So sex hormones first, and then thyroid second for me.
Okay, Russ, probably the same.
Yeah, I mean, repeat the question again. It's the feel-good chemical. Are you talking about how thyroid increases dopamine levels? Was that the question?
I think it was, the question was, how prevalent is the need to correct the thyroid levels
in which to optimize?
Okay. Yeah. And again, I have people that are, at the 11th hour, the new research, there's a lot of new research about looking at, thyroid T3 in some instances, to rule out some of the SSRIs. So we know that the thyroid does impact the neurotransmitter levels in the brain. I think it's a really good tool, like Jim said, to start with. I'm just going to echo everything he says. If somebody comes to me at the 11th hour and they're, I'm worrying about sending them home, or they're going through divorce and they're really in the tank drinking. Yeah, I think we know the SSRIs may be a bridge, but they damage the mitochondria and are going to make things worse at the end of the day. So the thyroid, my physicians have used Thyroid T3 for short intervals to help people get through that bridge of a bad time, and then obviously up their testosterone levels, check their thyroid, work on the microbiome. We also look at neurotransmitters in the brain. A lot of people are addicted to carbohydrates during this stage in their life. Why? Because the carbohydrates are bumping up serotonin, and maybe the only thing that's keeping the gun out of their mouth. So I'm not going to mess with anybody's diet when they're going through a hard time. I rather balance out the HPA-G axis in the microbiome, and then get some compliance, and then I could look in their eyes and know that, okay, we're going to get through another 3 weeks. I'm not going to just do a test on them and say see you in a month, because I don't deal with people like that. They need help now, and I mean, they have my team's cell phone number 24/7.
Yeah, I understand. Okay, I think that was it about the thyroid. Then another source of a question. I read something on Reddit and I was asked about it. Someone said I was using compounded test cream from Empower Pharmacy, 200 milligrams per milliliter. That's 20%. When used on my scrotum, it was pretty effective. My test levels after 12 hours were 840. But the problem was that it traced DHT like mad, he said. when used on the balls. Mine was 280 DHT. And the symptoms of high DHT in this case were mild acne and uncontrollable dandruff. So he switched to his flanks, but that was not a good feeling for the TRT effect then. So he asked long-term, should I stick with the scrotal cream and take some DHT lowering substances? So I don't know if that actually exists, DHT lowering substances in combination with TRT. Is he talking about finasteride?
I'm going to jump all over this question because I love that somebody asked this question. This has been there's been a lot of activity on the message boards talking about the transcrotal testosterone cream, and I use a version of it in my protocol, but I've just been sitting back quietly, not wanting to chime in because I'm kind of at odds with some of my colleagues in this area. For me, this is the same song, second verse. About 8 or 9 years ago, this transcrotal cream was kind of a fad, and some of the markets that I was involved in, and we were testing it, prolifically. I'm a data scientist. I like really collecting a lot of data on these things. So one of the things that you get if you're putting any place close to 200 milligrams or 100 milligrams of testosterone on your scrotum, you're going to have massive DHT levels. And you're going to feel, now what guys like is they love the feel of high DHT. It's a very powerful androgen. You want to have your androgen optimized. You'll get amazing results. But you can get, last week I had a patient that is, my protocol it's 25 milligrams of testosterone on the scrotum to try to optimize that DHT level. You will find even at 25 milligrams that guys will respond with a DHT in the 2000s. Can you imagine what happens when you put 100 milligrams or 200 milligrams on the scrotum? I don't have to imagine. I've seen the levels. It's in the 10,000s. And so you feel amazing for a very short period of time. But what I believe, this is my own theory, having worked with these situations, is that you create some receptor dependence and resistance, and you will start creating some receptor downregulation. There is almost no system in the body that doesn't obey these kind of laws of homeostasis. If you are oversaturating, overstimulating a receptor system, whether it be opioids, antidepressants, or dihydrotestosterone, you can create some resistance. Homeostasis will push against that. You'll downregulate androgen receptors, and then what felt amazing, Superman, bulletproof, awesome, can actually then lead to a very significant decline later on. And so, I encourage, and I've kind of been doing this mildly on the message boards, is go experiment all you want, but make sure you're measuring those DHT levels, and because you don't want to blow out your hair, inflame your prostate perhaps, or exacerbate an underlying, psychiatric disorder, because that's one of the things that you can also get from really high levels of DHT is you can get some psychiatric behavior that is not conducive to normal relationships. So I'm a little bit concerned about this hype of transcrotal testosterone only at the levels that we're talking about. And then more to the point is, it's fine if you measure it. It might work for you. Some people it does, and you might manifest with reasonable levels that are safe and effective. But if you don't measure it, and the other side of this hype has been, you don't have to worry about measuring it. It's awesome. You're going to feel great. Well, this is an area that I think that you need to measure. Follow your, check your DHT. And unfortunately, dihydrotestosterone in the lab test is one of the more expensive lab tests. It's, you're looking at about $120, $130 to test your DHT. So a lot of guys skip that, and they never see that their DHT levels are really, they're in the stratosphere. And I just don't think that's healthy. So I think transcranial testosterone has its place. I use it in my Man Up protocol. It's a combination of injections and a small amount of cream. And then, my cream includes pregnenolone, DHEA, and vitamin D, as well as the testosterone. So you create the baseline with the injections, and then you create a rhythm with the transcranial cream. In mine, you put 25 milligrams on the scrotum and 25 milligrams on the upper inner thigh. And then depending on what their follow-up labs look like, if they are really a hyper responder, like the gentleman that was in the 2000s, then we'll move it, to all upper inner thigh or as far away from the testicles as we can, because some guys just have a massive 5-alpha reductase system. And this was a pretty young guy that happened. And we know that 5-alpha reductase increases in older men. So you also have to be careful if you're a little bit older, because your transcranial response might result in a much higher DHT levels. I think DHT is one of those important measures that you want to have in the optimal zone, but not in the super, stratospheric, super physiologic level, because it's just not going to be good for you in the long term.
Mm-hmm. Okay, you have any experience with that, Russ?
Yeah, I think the micro dosing, we're leaning more towards micro dosing and even low dosing the cream. We find that over the last 10 years that not only the scrotal area for the cream, but the skin just seems to cause a large rise in DHT. And like Jim said, and made a lot of sense, I deal with a lot of bodybuilders that went south, and we try to rebalance their body chemistry. And I think the roid rage comes from exactly what he's saying, elevated DHT, neurotransmitter imbalances, because we know from studying psychoneuroendocrinology that if that dopamine stays in the synaptic space too long, that can lead to bipolar and schizophrenic symptoms, that scare the hell out of people when that happens. So, you've got to be really careful. I always like to dose low and dose slow. And like Jim said, follow the patient. Don't get caught up in 1960 bodybuilder numbers and think about putting on, 20 pounds of muscle mass. Because if you put on 20 pounds of muscle mass, think about what you're doing too. And I'm not shooting down bodybuilders. I learned so much from them and the endurance athletes. But if you're gaining a lot of muscle mass and you're eating 6 meals a day, elevated insulin, hemoglobin A1C, IGF-1, and then you've got toxins in the environment, that's not good. That's a perfect storm for diabetes and a whole hell of a lot of other problems.
Okay. Then before we jump into the Q&A, because I already got a lot of questions in the chat box, one more question that I had prepared for you guys. So if we give a man TRT, whatever the delivery method and whatever the dose, and we optimize till he feels great, so we go for the symptom resolution instead of looking at the numbers. And if his symptoms are gone, and then we check the T levels, and the total T levels, for example, seem to be in the 1500s, 1800 ranges, and can we sustain this, and is this healthy levels in the long run? Because I've already had people calling these levels abuse or even supraphysiological. Do you agree with that, Jim? Are those numbers 1500, 1800 abuse?
No, I think it's individualized, and we know that, we know from, again, a number of studies that is where some people live in their, most vital, strongest, best, immune system, ability to recover from injuries. That's where they were when they were, younger. And so returning them, to that area. So if we were to take the kind of the more traditional view of this, and we took an individual that's always been an elite athlete, high performer, at a level of excellence, and they had testosterone that was in the 1800 range. And then we're treating them, they're suffering, they're depressed, they're gaining weight, not recovering from exercise. And we're going to keep them, someplace below 700 or 800. I mean, that's a, half to a third of what their body was used to. I mean, their physiology was designed, neural synapses had been created, feedback systems were built in the body on the basis of a whole different physiology, and we're returning some fraction of that. That doesn't make any sense to me. So, I think we have to pay attention to the biphasic response that can happen with, true supraphysiologic treatments. I mean, if you start, the evidence looks to be you get above 2,500 total testosterone, a correspondingly high free testosterone, that you might, that there's some mechanisms that come into play that can erode health. So I think that we have to be attentive to that. There's ways of measuring those kind of things, but I don't get worked up by a 15 or 1,600 as long as everything else is going well. Sometimes I'll say I need to speak to your spouse, because sometimes they're the ones that are the best register of, especially in this DHT thing that we just talked about. They're the ones that notice. Sometimes when you're under the effects of these supraphysiologic dosing, you may not be the best judge of how it's resulting in your behavior. And sometimes it's your spouse that is a better register. And I have talked to a couple of spouses. Many times they call me and say, whatever you're doing, I need you to stop, because, John has become, aggressive, mean, combative, those kind of things. I don't know, Russ, have you ever seen anything? Have you ever had spouses?
I grew up in this town I'm in, and yes, I've had wives come up to me and say, listen, I don't have enough time to be doing what he's doing right now. I don't have time to have sex 3 times a week.
Yeah, well, that's the other one, right?
Yeah, I've heard it all. So
yeah,
no, I understand. Yeah, and that's where we get to the individual treatment. And no, like you said, Jim, when you pull a spouse in, I always sit with couples when I'm doing a discovery, brother, for the same reason.
Very good. Yeah.
Okay, that's clear. So we won't get worried about the 1,500 then.
No.
Okay, thanks for answering those guys. So from the chat box, I picked 6 questions. I won't pick any more because we're already at the 1 hour mark already. So we can keep them rather short, guys. So I'll start with the first of 6. A guy wrote, it seems that most of the individuals on TRT are in their 40s and 50s. Can you comment on the longevity of using TRT? Do you have success stories of people on TRT long-term in their 60s, 70s, or 80s?
Absolutely. I mean, I think it's, I have patients that are in their 90s. I have a gentleman that's 94 years old, and he remarried about 2 years ago. I mean, it's a much younger woman too. This guy he's awesome, but I think we're missing the boat on treating a lot of our elders that are suffering from a number of chronic diseases. Oh. They have the most to gain. When you are watching, a family brought their father in recently, and they were telling me this story. He was a World War II veteran, and now he sits in the living room looking at the ceiling, no TV on, nothing, major depression. His health is, his health is just wasting away. And he's always been a vital, healthy man. And he comes in and he's got a free testosterone that's like 1.2, and all of his measures are off the scale. And he's, like I said, he's 85 years old. And he has the most to gain from, that kind of a treatment. This is a lifelong, I hope to be over 100 years old and running with my great grandkids, right. With my hormones optimized, with still having some muscle mass, still having good, strong bones. I want to be like Russ. I mean, you're not that much older than me. I didn't mean it to come off that way, Russ, but you are you're a healthy, vital man that is still, active. And I'm, and I'm 54 years old, and I'm still, doing jujitsu and not as well as I used to, but I'm still doing it, and I can still play paintball with my kids. Yeah. I mean, I think you need to look at this. If it's done well, gentlemen, the longevity of this treatment and the longevity and vitality of your life, it's going to be one of the best investments that you ever made. If I didn't think that, I wouldn't be doing it myself. You know, I dug into the science, and I am 100% convinced that when done right, this is one of the most powerful health interventions, preventative interventions that we could possibly engage in.
Oh my God, I agree, 100%. One of the other areas that I want you guys to think about is, you know, guys, I've been studying heart disease and endothelial dysfunction for 30 years. Ever since I was a kid, with those people dying in my arms that were really thin, I always had questions the doctors couldn't answer for me. So whether it's vascular dementia or the arteries that surround our heart, Jim, you know how important the testosterone nitric oxide is, measuring asymmetric dimethylarginine to keep these people in the game. Our circulation is gonna, I want to be able to run at least a 10-minute mile when I'm 100. I just want to be able to get around the track, because I think the circulation and the muscle and the bone, that's all going to come into play, but we need the testosterone and the right amount of thyroid and the right amount of cortisol, because to keep those arteries open. I started looking at really fit athletes that have had heart attacks at 35, and we were tying it into suppression of the HPA axis, along with inflammation from the overtraining and the high carb diet and imbalances in the microbiome. And I've been on this, like a crab. I'm trying to really get this out into the cardiology market, Jim, to have them start looking at this for endothelial dysfunction.
Completely agree.
Mm-hmm. Okay. Next question I had from the chat box. Is there any research or anecdotal evidence that TRT can help with chronic joint pain and inflammation and cartilage repair on people with arthritis? I guess that's your area, Russ?
Yeah, I think, with all the athletes that have low testosterone, and we know, like Jim said, the body's on fire. Well, if you're overtraining as an athlete, whether you're running 70 miles a week, cycling 400, your joints are going to take the hits. A lot of massage therapists know this because they deal with these people all the time trying to work the kinks out. But as we all just discussed here earlier, if you optimize testosterone and you optimize your thyroid and really take a look at your adrenal function, you could suppress that inflammatory response. And here's another thing nobody thinks about. Testosterone on the cellular level helps the cells produce less free radical damage. And that's another area that I think we're all going to start seeing bubble to the surface here sooner than later, because joint pain. I work with orthopedic surgeons, and the orthopedic surgeons go, you know what, Russ? This is something I always see. People on testosterone, man, they always heal faster. I have had a bunch of them tell me that over the years. And getting back to that same on a cellular level, nitrogen balance, protein synthesis is all stimulated by testosterone and the right balance of thyroid and cortisol.
I've got nothing to add to that. Russ nailed it. That's for all of those many reasons. He's exactly right.
Okay, so we'll go to the third question from the 6 that I picked from the Q&A. Transdermal testosterone application before going to bed keeps me from falling asleep. Should I only take it in the morning? So is that a regular complaint you hear, guys?
Yeah, I do.
Yeah, I think so. I mean, it can be stimulating for some people. He answered his own question. Your sleep is so important. If anything is disrupting your sleep, stop it, change it, move it around. You have to listen to your body. And when it tells you something as important as that, then yeah, you move it and you just do it in the morning. I recommend the dosing be in the morning, because here's, transcrotal, transdermal. It has a very rapid absorption. It's going to, peak a few hours after application. Transcrotal about an hour and 15 minutes. And then it's going to decline over transcrotal declines over about 16 hours. Transdermal about 22 to 24. So, and the other reason you put it in the morning is, what is our normal diurnal rhythm of a man? We need to pay attention to what nature teaches us about our hormonal rhythms. They're very important. Look at what we're doing wrong in women's hormones when we treat them with static dosing, the same dose every day. That's not the way women's hormones. It's a symphony of hormonal changes throughout a 28-day cycle. Men, we have a 24-hour cycle. So, you know, why you would create a testosterone peak and, you know, at 10 a.m. or 10 p.m. or 11 p.m. when that's the opposite thing is typically happening in your physiology. So you put the Transcritical on in the morning after you get out of the shower, and you allow that natural rhythm to be replicated. We're just copying nature.
Exactly.
Okay.
We have a lot of, I have a lot of, you know, emergency service personnel, you know, executives and war veterans that can't sleep at night. They got disrupted sleep patterns. They go to sleep studies. And sometimes, like Jim said, you give, if they're using the testosterone after 3 o'clock, whether it's skin or microdosing injections, it kind of ramps them up at night. So let's take a page out of the book called Potatoes Not Prozac. And we try to let them increase their simple carbohydrates at night to elevate serotonin levels so they can slide off into REM sleep. So these are some of the tools that I utilize for my, you know, a lot of my clients are super high stressed. So like I said, I got to get them sleeping first. You don't get them sleeping, nothing happens.
That's exactly right. I mean, it's in the, you know, deep stages of sleep, stage, you know, 3 and 4, deep sleep, that we produce growth hormone. So we got to set ourselves up for the production of one of the most powerful regenerative hormones in the body. We got to optimize deep sleep. Anything that, you know, that works against that, including every sleep medication on the market, they all disrupt, you know, deep sleep and destroy our growth hormone levels. So yeah, that's, you know, so I know that question is probably partially related to some of this message board hype stuff about, you know, transcranial testosterone twice a day. I'm not a big fan of the twice a day thing for a lot of reasons, but if you're going to do transcranial or transdermal only, you know, you got to realize that you're probably going to have to do it twice a day. You're going to need to move it earlier in the day, because you're going to peak and then return very rapidly to kind of your low level baseline. The reason in my protocol that we do an injection as well is because you want to bring the baseline up with a long acting, you know, like a cypionate ester has a 5 to 7 day half-life in the body. And so you create a baseline with the injections, and then you replicate the rhythm with the transcranial transdermal combination. And I think that gives you better levels. You don't return back to, let's say you were at 200 total testosterone. You go on therapy, you're doing transdermal only, you know, you peak, come down, you're coming back down to 200. Nobody wants to be back at 200. So, you know, build a baseline with some long acting testosterone injectable esters, and you'll feel better, sleep better, everything heals better. All of the benefits come from kind of a more balanced approach.
Mm-hmm. Okay, 3 more questions, guys. For all the viewers watching, they're still sending more questions for the moment, but I've already picked 6 that we are answering. We've done 3, we'll do 3 more. Save your questions for the next roundtable, please, or maybe post them in our Facebook group called TRT and Hormone Optimization Therapy, HOT. These great guys are in the group together with the other doctors. We can all help you out there with your specific questions as well. So let me go to the 4th one. It seems you guys and many of us are serious athletes whose T crashed and require TRT. Can we continue to be serious athletes on TRT as we age without crashing again? What's your experience with that, Russ?
Yeah, I think, you know, I deal with a lot of aging athletes, and like Jim will understand, you know, sometimes I was a triathlete and I was doing everything wrong. It took me 10 years to become one of the fittest cyclists with my group, and I had to stop all of it and walk away. And that's really hard to do. And it's really hard for a guy that was an athlete his whole life, or a woman, to stop. So you've got to, you know, I always say, show me your 3 friends, I'll show you your health. You've got to make, you know, this TRT stuff is great, but if you have unrealistic expectations, you're going to hurt yourself. You're going to be miserable because you're going to be always chasing the carrot. I mean, what's important? I think we realize what's important. Like Jim said, he wants to be with his family. He wants to do jujitsu, not like he used to, but he wants to stay active when he's 100. He didn't say he wanted to run a marathon when he's 100. He said, I want to be active. Well, one of my earliest educational experiences was as a paramedic in the early 80s. I went into nursing homes. That's an education for me. I took people in and out of nursing homes. I watched them deteriorate from chronic disease. And then fast forward 20 years, I was setting up anti-aging centers and seeing people in their 60s and 70s. And I'm like, that's what I want. But I had to let go of my competitive spirit. I had to say, listen, I'm going to slow down. I can't do 100-mile bike rides anymore, even though the community is great. I had my tribe with me. I had to find another tribe. You know what I mean? So I mean, we really got to look in the mirror and say, listen, it's about quality of life and what we do to keep our ass off a bedpan.
Yeah. You know, my contribution to that is, you know, a lot of competitive elite athletes have had repetitive brain injuries, and they probably have contused, you know, their pituitary. I've seen a lot of panhypopituitarism, you know, where that little fragile, amazing structure, the pituitary, setting in this bony little cavity. I mean, it just swings into that wall and you can damage it. I've been knocked out several times in my fight career and my tournament career. I have very little doubt that there was some damage done there. It's one of the questions I always ask in the intake is the history of concussions. It's a bigger issue than people realize, and it has a bigger impact, and it can have a lifelong impact that's very difficult, much more difficult to deal with. Fortunately, we have a lot of more tools in our tool bag than we used to. Peptides have a tremendous amount of promise to replace some of that growth hormone capability that I think gets lost when a lot of these pituitaries get injured, brains get injured. But, you know, sometimes athletes, we're our worst enemies in terms of, you know, trying to extend our career longer than we probably should. You know, it's rare that you have a Randy Couture that's able to, you know, to perform at the level he did at the ages that he did, and, you know, 48, 49, and still competing at the highest of levels. But it can be done. But man, you got to know, you got to get wise. You know, wisdom comes with age. Not very fast in the Meehan clan, but I finally figured it out that, you know, I really need to stop getting, you know, ligaments and tendons torn by 25-year-old beasts. And, you know, I needed to take it down several notches and reconsider the level that I'm going to perform at. We all have to do that at some point because, you know, there is a wear and tear that no level of hormone optimization is ever going to be able to replicate that youthful, perfect systems that, you know, were perfectly designed to and calibrated to, you know, to restore damage. You know, no system that Russ, myself, or any of our colleagues could provide could ever replicate that perfect system of youth. So we can get close to it, but it's not really that close. So, you know, you got to slow down and bring it back to something that is, you know, I think cycling is a great thing to do. You know, you're outside and it's not so repetitive, you know, injuries. But, you know, don't be afraid. Don't think you're a wimp because you're doing yoga or something, you know, something like that, but do something. You got to keep moving. That's for sure. But it may not be, you know, fighting in jiu-jitsu tournaments every other month.
Right.
Okay, probably. Do you see, guys, an increase with insomnia or anxiety once starting man on testosterone? I mean,
like I said, with the people that I deal with the outliers that are extremely in a bad spot in their life, and what Jim mentioned to earlier, we have to look at the neurotransmitters and really pay attention to that DHT because it could exacerbate. You know, I don't like using the word mental illness because I think they're all labels. There's no blood test for bipolar. There's no blood test for schizophrenia or depression, but we know those are symptoms that people have. So I think depending on where you are in your life, I do think that these things could be exacerbated if you're not optimizing the testosterone the right way and looking at the areas that we're talking about here today, the microbiome, you know, the mitochondria, you know, the DHEA axis and the environment. And basically, you know, where are are you and where are you in your life? What is causing the most stress in your life right now? Is it the job? Are you in a job that you hate? Are you going through a divorce? Are you in an unhappy marriage? All that comes into play. Like when I'm doing a discovery.
Mhm.
Well, I think it has less to do with testosterone and hormone optimization therapy than it just has to do with all the other things that surround that. I mean, we got too much, blue wavelength, high energy light stimulating our photoreceptors, disrupting our melatonin. If you got your face in Facebook at 10 o'clock at night, you're not going to sleep well. You're going to disrupt a whole bunch of things. You got it. There are a lot of things that we have control of to improve our sleep. The electromagnetic fields that we're saturated in, if you've got your iPhone plugged into the wall and then setting, 6 inches from your head, you're not going to sleep well. If you've got a lot of electromagnetic field in your bedroom, you're disrupting your sleep. So, there's so many things that we can do to improve our sleep. I think hormone therapy, in my experience, done well is more, supportive of optimal sleep, but it's not a treatment in and of itself. You also you got to do all of these other things to improve and optimize your environment for sleeping, your mind for sleeping. You got to learn to shut it off and journal your worries, close it, and worry about tomorrow instead of laying there in bed worrying about what you're going to do. What all the problems and the battles that you've got to fight. So I think it's, as long as you are you're measuring your responses, your lab levels, you're on a good hormone program, you should have some of the essential elements for optimal sleep, not the reverse. But again, if you're having some problems with sleep and you think it's related to your hormone therapy, you might have to change things around, like the gentleman in the previous question. Listen to your body. Experiment with your body, work with your doctor to move things around, change the dosing, change the timing until you find something that works for your specific physiology. But be careful about the correlation equals causation, because it's just because you started your hormone replacement therapy and now you're not sleeping well, but you're kind of ignoring all of the other things. The fact that you drank 2 glasses of wine right before you went to bed, or that is your standard kind of routine before bed. Any high sugar, carbohydrate laden meal too close to bedtime is going to disrupt sleep. Alcohol is going to disrupt sleep. So really pay some attention to all of these other causative factors and investigate them all to get a better idea as to what really is causing the problem.
Okay, that's clear. So one last question that was for Ross. Ross said that thyroid meds stress the adrenals. Can you explain how T meds do that? Or did I misunderstand?
Well, what was that again?
How do thyroid meds stress the adrenals?
Well, yeah, a lot of times, and we see this again, it's not a sweeping generalization, but a lot of people that are just taking thyroid medication at a certain dose and their symptoms are not, and they're not doing the proper blood work and their symptoms aren't dissipating, it's because the doctor isn't looking at the adrenal glands. So if you're treating the thyroid in isolation like they have been for 100 years and not looking at, reverse T3, as Jim mentioned earlier, free T3, free T4, not looking at the microdosing of testosterone, you really, if you have an elevator that goes to the 100th floor and you only treat T4, you're only going to the 50th floor, if that makes sense. So remember, thyroid and the adrenal glands, they work together. And one thing that's clear, everything is interconnected and we are all biochemically unique. We have to ask questions. We have to keep a logbook. We have to, really, write down how we're feeling and keep a logbook to track this stuff, because you can't lay this all on the doctor. You got to step up and be proactive with your health, and ask the tough questions.
Okay.
I completely agree. I don't really have much to add to that.
Okay. Thank you, guys. We'll stop the questions now. Before we end, and that was actually an idea of Dr. Keith Nichols. Too bad he couldn't make it today to join us. But Keith Nichols proposed that we do a bro science section on the end of the roundtable each time. So I would ask you guys, what piece of bro science, what best or maybe worst piece of bro science did you hear or read online in the forums, on the message boards the last weeks? Any funny stories or questions that you read? Jim, anything?
Yeah, so I mean, I'll kind of double down on the, the transcrotal DHT. Don't worry about measuring it. That there's so much right now. There's a bunch of hype along those lines. I mean, try the transcrotal approach, transcrotal testosterone only approach, but don't ignore your lab levels. You really need to know what, you need to know what your DHT levels are doing. You need to know what your estradiol levels are. I think that any advice that is, no, just put it on, put that cream on your scrotum and don't worry about it. As long as you feel good, you're okay. You're always going to feel good in the beginning, and then it's going to kind of start to tail off, or you're going to start blowing out your hair, your prostate. There's other things that can go wrong if you're not really watching some of the super physiologic results that can sometimes happen. So measure and monitor is reasonable advice.
Okay, Russ, you heard anything funny of bro science last week?
I think the bro science to me is like when somebody uses the term sheeple. I think we're all on a journey. I love the bro science because everybody's asking questions. There's something powerful and transforming about asking questions. So I don't, of course, this all evolved from the bodybuilding industry. And there's three types of people that want to, put on muscle mass, people that are interested in performance, people that just want to get through the day, like Jim, and live to be 100. And then there's some guys that have an undiagnosed pathology. So the bro science is a good thing because it gets everybody thinking.
I agree with that. I learned a lot more from the message boards in the early years than I ever learned from any medical textbook or lecture. So I agree with Russ 100%. There's a lot of very smart people out there giving good advice. I mean, Russ has been on those message boards for a long time. I was very glad to see that I got to speak with you today. I've been following your advice and work for a long time. And, there are those people that have been contributing for a long time, and they really know what they're talking about. And there is some good advice out there. You just have to be discerning in that advice, because just as there's great advice, there is really horrible advice. And there are, there's just some people that seem to chime in and they don't know quite as much as what they think they know. And they tend to be some of the most vocal voices out there. And they also tend to run off a lot of us, like Russ and many of my other colleagues. I mean, I get on those message boards and I always go, why do I, because somebody's always got to get adversarial about it. I just want to share information, and I want to kind of progress the science and learn from each other. But there's some of those guys, I think they're all high on DHT sometimes, that just want to argue.
I don't understand the medical system where, the third leading cause of death in the United States is our own medical system. We all need to stick together. Why people compartmentalize and act that way, I have no clue. It blows me away.
Yeah. Good stuff.
Okay, so let's round this one up, guys. Maybe first, you, Jim, if people want to reach out to you, work with you, or contact you, what is the best way to do that? Your website and other contact data?
Yeah, you can just, my company is Catalyst MD. You can find me through meehanmd.com, or you can contact support at catalystmd.com. That's CATALYSTMD.com. And that's probably the best way to get into our program. And I am accepting new patients, and always happy to help people just do what I did, transform their lives, become, you know, someone that's working in their purpose and fulfilling the purpose for which they were perfectly created. So I just love doing that. And I'd love to help anybody that wants to do that with me.
Okay, great. And you, Russ, I looked into your website today. It's a beautiful piece of work.
Thank you. Yeah,
So
so
tell the people how they can reach you.
thank you. You could go to Scala Precision Health. I've got a team in Orlando, Florida. We do a lot of online training. You can see my book on Amazon. I put it in the Kindle version. It's American Biohacker. And that's on the Kindle version on Amazon right now. We just published that book a while back. And then I started the Russ Scala YouTube channel, sort of like what you guys are doing. I just want to get information into people's hands. And that's sort of my way of paying back for, listen, I was a paramedic attached to the SWAT team. I didn't think I was going to make it to 40. So I'm in my 60s now, and thank God I'm happy every day I get up and stare at my feet. And I want to partner with guys just like you. That's it.
Okay. Anything more to add, guys?
No, that's good for me. I really enjoyed it. Russ, it's great talking with you and working with you. We're on the same team, brother.
Okay, man. Good too.
You too, Steven.
Thank you so much, guys. I stopped the